Professor Hollis Potter from New York, HSS, a radiologist, world-known radiologist, one must say. And you are talking to us about MRI and hip joint preservation, a very important topic. That's our new anatomy lab, the MRI.
Thank you, and thank you to Professor Seibenrock for the kind invitation to speak today. I was asked to give an overview on the use of MR, so some general and a little more specific research use. These are my disclosures. So we all know about looking at cartilage on MR. It's important to remember that it is a normal grayscale stratification that reflects the orientation of the collagen in the extracellular network with lower signal intensity as we get closer to the tide mark. We can use MR as a means by which to determine suitability of our surgical approach for patients. We do this at HSS, determining if someone is really more suited for an arthroplasty compared to a preservation technique. So if we look at this patient as sagittal images, you can see extensive bone-on-bone opposition, so clearly would be arguably not amenable to an arthroscopic approach. But if we look at this patient with dysplasia, the cartilage thickness is relatively preserved, and you look carefully, you can actually see loss of grayscale stratification. So the cartilage thickness, while preserved, is abnormal in terms of its collagen orientation and grayscale. So the presence of preservation of joint space on an X-ray does not preclude significant chondral wear. This is a 52-year-old lady with really normal radiographs. You can see she's dysplastic. She has areas of full thickness cartilage loss over the femoral head. And then, of course, we want to separately evaluate the acetabular dome. And you can see pretty substantial cartilage loss. Now, we can also routinely take axis along the long neck. And this was really devised here from the Swiss literature, where we use these routinely now. We call them our Swiss axials, simply because it was so nicely developed here, but you can evaluate the offset. And then, of course, this is now amenable to measuring on MR your alpha and beta angles. In young patients, we always evaluate femoral version as well. You can get a low-resolution image of the distal femora and then provide a measure of femoral anteversion or retroversion on the same imaging test, and obviating the need for ionizing radiation from CT. So I published some time ago the use of non-contrast techniques, and now with deep learning techniques that are available in denoising, we can get very high-resolution scanning that, in my opinion, obviate the need for intra-articular contrast. These are 4 different patients with 4 labral tears that are very easy to see. So when we think about the male pattern, there's the classic male pattern, often with a big offset, anterior offset. It's also important to think of the 3 dimensions of the hip to look posteriorly, particularly if pain is more an extension as opposed to flexion and internal rotation. See a anterior labral tear and a large focus of ossification anteriorly. Women, however, can be much more subtle, and I'm just going to put it out there because often female pattern, they don't have the big CAMS lesions. They're often much more subtle. We can see, and what I look for in the female patients is subtle neck notching that can be characteristic of a female pattern of FAI. Note the over bony containment you can see anteriorly as well. So just do a little case study here. This is a professional ballerina. So when you think about a ballerina walking into your office, you're thinking, well, maybe she's coxavalga, she's going to be hyperlax, dysplastic. She has a stress reaction in the posterior column on the left. You can see that bone marrow edema pattern. But lo and behold, when we look at her, she's not coxavalga, she's not dysplastic, she has lateral and anterior over-containment, so that when her profession requires her hip to go into the extremes of flexion and rotation, it's going to create undue stresses of the posterior column. So when you have all this wonderful information in MR, it's important to look at all the different pulse sequences to put the whole picture together. So bone typically on MR has very short relaxation times and therefore is typically seen as signal void or black on MR. Using newer pulse sequences, however, we can actually generate CT-like images. So that's a CT, but this is an MRI with appropriate post-processing, and this is called zero echo time imaging. that we worked on in collaboration with engineers in my lab. So here's a comparison. These are published in American Journal of Sports Medicine, where we looked at coronal CA, sagittal CA, and acetabular version at 1, 2, and 3 o'clock. And when we looked at the intermodal agreement between CT-MR, we actually had reasonable reproducibility and accuracy of ICC. And this is just showing you, again, in a different cohort, just looking at the intermodal agreement. So now we can have these CT-like images. These are very amenable to 3D modeling. And so we can actually do a simulated adduction and internal rotation view. And in silico, we can actually model the hip in different cohorts, looking at the range of motion and the nearness, if you will, between the femur and the acetabulum. So if we look at these, we have a morphology. We have some patients with dysplasia, some patients with femoroacetabular impingement, and we have a small subcohort postoperatively. We can see how they appear in the flexion and internal rotation tests, again in silico with these 3D models. We can actually also look at the results of, you can see the acetabular dysplasia. So if you just look at this carefully, you can see that, in fact, internal rotation is on the x-axis, adduction is on the y-axis, and that the proximity, if you will, between the femur and the acetabulum, widely available in a patient with dysplasia, not so with a patient with femoroacetabular impingement. And the surgeons at HSS love this because I can actually evaluate how they do in the OR. I actually enjoy it quite a bit. And you can see in the preoperative on the left and the postoperative, that nice increase in the range of motion that was available in this in silico modeling. Not so nice in this other patient where you can see this is postoperatively. Again, they have very little change. And you can see on the 3D models, the debridement was incomplete, the cause of the problem. It's important to also think about instability, and we have a nice ability to see the capsule had the beautiful demonstration of ultrasound of the capsule. MR can see the capsule as well. This is a patient with excessive femoral anteversion. One could argue, was she really suitable for a neck debridement? Unfortunately, did come to us that way. You can see she has edema pattern against her psoas, indicating that she's moving forward. Her iliofemoral ligament was not appropriately repaired, and you can see that there's impaction over the anterior portion of the femoral head because of her anterior instability. Similarly, in this patient, you can see there's gross disruption of the capsule, and this is why I really like non-contrast techniques, because I want to see that native capsule, the presence of extracapsular soft tissue edema. You can see the anterior translation of the femoral head, and you can also see that, unfortunately, there's full-thickness cartilage loss there by the yellow arrows with a big fragment in that lateral recess. So she's delaminating cartilage pretty actively. Deficient iliofemoral ligament with a blue arrow, and that anterior translation with the red arrows. Careful where the suture anchors go. Again, just unfortunately, these are violating the tide mark here anteriorly, and then in another patient violating towards the psoas, and patient had quite a bit of pain with flexion, as you might imagine, and an appropriately done patient on the bottom. You can see that nice purchase close to the tide mark, but not violating into the joint proper. Of course, we always want to evaluate the extra-articular portion as well. Abductors, we follow the piriformis here. We can follow the short extra rotators, posterior footprint of the gluteus medius, anterolateral footprint, and close to the gluteus minimus. So when these are affected by tear, we think of them, of course, as the rotator cuff of the hip, and looking for the degree of not just tear, but the degree of muscle atrophy and the suitability of the tissue for repair, perhaps requiring a gluteus maximus transfer in the face of very deficient tissue or some sort of a tissue augmentation technique. Again, there's a denervated gluteus minimus, very commonly we see. Be careful about the subchondral insufficiency fracture, characteristically lots of bone marrow edema pattern on one side of the hip with that obnoxiously subtle low signal intensity focus we can see here. And this is, of course, distinctive from AVN, which is the classic appearance of AVN, not the subchondral fracture. As we follow these patients tomographically, look for subtle offsets of the tide mark. In my experience, they offset delamination 1 year later. You can see that same area where it was very subtle on the previous scan is now obviously delaminating and collapsed in the subchondral bone. dead bone, low signal and all pulse sequences. We've done some work with perfusion analysis, and I would say that most of the time that's not really necessary. If I can't move water on it, it's not going to bear up to any kind of restorative technique and will have to be debrided. Last but not least, it's important to think about things like synovial proliferation disorders. This is a characteristic appearance of gradient echo imaging in a pigmented villonodular synovitis, very fast loss of cartilage, and synovial chondromatosis with the erosion that's very characteristically seen here. Think outside the box. This is a case that was sent to us, an outside MR. We rescanned her at HSS. She had a diagnosis of dysplasia, which she clearly has, and was read as having a large bone island, which doesn't make sense because the bone island is very eccentric and a large amount of edema in the hip. And I love to do this with teaching, kind of to put it as an unknown. I'd love to be able to poll the audience, but this is actually not, I'm sure someone already knows it, is an osteoid osteoma, just a very large one. So it's important to think outside the box. When in athletic patients, we always include images of the pubic symphysis. They often coexist with femoroacetabular impingement, so we're looking for the micro tears at the adductor longus origins in the so-called sports hernia or athletic pubalgia cases. Okay, and this is a professional dancer. Now, she does kind of fit that nice category. She's a little dysplastic. You could argue coxa valga here, and has edema posteriorly, and this is kind of the characteristic appearance of ischiofemoral impingement with edema by the quadratus in the posterior margin. Again, don't forget this kind of thing is a 17-year-old rule-out labral tear, markedly thin cartilage, but you also notice there's a bone marrow edema pattern by the SI joints and in the acetabulae, and this is a seronegative spondyloarthropathy. So we always want to think outside the box. So again, MR is a very useful tool. We can use it, we use for cartilage relaxometry, and Professor Kim is going to be showing some nice degeneric data to that end, but we use it extensively at HSS as a tool. It's important to think of all the pulse sequences provide, and it's fun to think about these new sequences that obviate the need for concomitant CT in these younger cohorts. And I thank you for your kind attention, and I'd like to acknowledge the NIH for support.